Good morning, dear colleagues and guests. Bienvenidos al seminario virtual abordando la salud de los hombres y las masculinidades en las Américas, un imperativo de salud pública. Welcome to the webinar Addressing Men's Health and Masculinities in the Americas, a Public Health Imperative. My name is Carolina Holmes. I am the advisor of the Healthy Life Course Integrated Approach at PAHO, and it's my pleasure to co-share this interesting webinar with my colleagues Jessie Schott-Ain from PAHO and Professor Derek Griffith from the Georgetown University. The webinar is co-organized by the Global Action on Men's Health, the Center of Men's Health Equity from Georgetown University, and PAHO. Today, we have a selected and experienced panelists that will share their knowledge and expertise in the area of men's health and masculinities across the life course, as well as regional and country perspective. Before we start, I want to share with you some instructions. Brenda, can I ask you to share the instructions, please? Today, we will have a simultaneous translation. Continuing in the meeting implies consent for recording. To access the language of your preference, please go to the bottom of your screen. There you will find an icon with a globe shape. If you click there, you will see two options. If you click again in the language of your preference, you will have access to it. The chat has been enabled so you can share relevant information and materials. During the questions and answers sections, you can use the chat to post your questions or experiences. Thank you, Brenda. You can remove the slides. Please let me take a few minutes to introduce the first three set of speakers who will provide the opening remarks. The opening remarks will be conducted by PAHO's Deputy Director, Marilu Valdez, followed by Peter Baker, Director of the Global Action on Men's Health. We have also a special guest, the Honorable Minister of Health of Guyana, Dr. Frank Anthony, who will provide the opening statement. Now, I would like to invite our Deputy Director to provide the opening remarks. Fernando, please.
Distinguished guests, dear colleagues, ladies and gentlemen, it gives me great pleasure to welcome you to this virtual event, Addressing Men's Health and Masculinities in the Americas, a public health imperative. I wish to express my appreciation to the Global Action on Men's Health, the Center of Men's Health Equity, Georgetown University, and my PAHO colleagues for co-organizing this important event. I would also like to recognize country representatives and experts who are joining today to share their expertise and experiences on this topic for our member states. Dear colleagues, in the region of the Americas, the area of men's health and masculinities has generated much interest, not only in response to a greater focus on women's health, but due to the differences between the trends and trajectories of men's and women's health. These differences begin early in life and persist throughout the life course to advanced ages. The way men and boys think about and project an image of themselves as men and how they respond to gendered social norms and pressures has been identified as an important part of the explanation for unhealthy behaviors and premature death in men across the life course. The evidence shows that statistically, men are more likely than women to die before the age of 70 and have a higher mortality rate across the life course. The differences in mortality between males and females peak during adolescence and early adulthood when gender socialization becomes more pronounced, with male death rates increasing substantially, primarily due to violent causes and suicide. We also see that men are having higher mortality rates from COVID-19, which may be linked with higher incidence of cardiovascular disease, hypertension, type 2 diabetes, chronic obstructive pulmonary disease, and tobacco use in males. Other factors also help to explain this trend. Men are more vulnerable than women to some infections due to underlying biological causes, including immunological, hormonal, and genetic differences. Men also tend to have poorer general health and reduced access to health care. These differences have contributed to a sex gap in life expectancy. Life expectancy at birth in men is on the average 5 years less than in women, and it is estimated that this gap will increase over the next 15 years. This gap is also observed in the geriatric life expectancy. Even though life expectancy at age 60 and 80 years old for men has increased in the last decade, there is still a gap of 3 and 2 years between men and women, respectively. For the Pan American Health Organization, addressing men's health and masculinities is a priority to advance universal health and the gender equality agenda. Distinguishing women and men's health needs will lead to a major improvement in health, since both are different in many aspects and therefore require different health approaches, but also their health behaviors influence each other. These improvements in health would not only benefit each of these groups, but there would be a shared health improvement for men, women, their families and communities, and across generations. Today's webinar will stimulate the discussion on many of these issues and will open the door to questions that need our attention. These include, what can actually be done? How can the Sustainable Development Goals and universal health coverage be delivered if men are left behind? We at PAHO are convinced that efforts to improve public health must include attention to both men and women's health, reducing gender equality, and improving well-being across the life course. I hope you have an engaging virtual event and a deep discussion that will spark efforts for identifying and implementing effective solutions in men's health and masculinities across our region. We need to work together to advance universal health and the gender equality agenda. My sincere thanks to all who are here today and have supported this virtual event. I look forward to learning about your discussions. Thank you and good luck.
Okay, so after this, our Deputy Director words, I would like to pass the floor to Peter Baker. Peter, the microphone is yours.
Thank you very much, and hello everybody. On behalf of Global Action on Men's Health, I'd like to welcome you to this very important webinar. I'd also like to thank PAHO and the Centre for Men's Health Equity at Georgetown University for the opportunity to collaborate on this event. For those of you who don't know Global Action on Men's Health, we're an international charity based in the United Kingdom. Our role is to push men's health up global and national health agendas and to make sure that men's health, alongside women's health, is taken fully into account in research, policy, and practice. Why do we do this? It's quite simply because men's health is unnecessarily poor, not only in the Americas, but around the world. Men have shorter lives than women, especially those men who are disadvantaged because of their income, race, gender identity, sexuality, and many other factors. The experience of COVID, which has so far caused around 9 million excess deaths in men worldwide, and that's around 60% of all deaths, has revealed very clearly some of the main problems in men's health. The greater incidence of those underlying conditions, such as high blood pressure and lung disease, that lead to worse COVID outcomes. Lower compliance with prevention guidance, in this case including vaccination, especially in the younger adult age groups. And there's been an almost total lack of male-targeted interventions from governments and health services. But we know what needs to be done. We need health policies that take men into account, health services that engage men more effectively, and more research into how we can deliver the kinds of programs that work for men. These initiatives are now beginning to happen, but on a scale that is too slow and limited. However, I'm very hopeful that this fantastic webinar will kickstart a new and more urgent approach to men's health in the American region. So thank you everyone for coming, and I hope you will find the next 90 minutes both interesting and inspiring. Thank you very much.
Thank you so much, Peter, for your words and for highlight the importance of advancing the men's health agenda in the region. Now, I would like to invite Your Excellency, the Minister of Health of Guyana, Dr. Frank Anthony. Dr. Frank Anthony, the floor is yours.
Thank you very much. Thank you very much for having me at this webinar. I want to thank PAHO and the Global Action on Men's Health for co-organizing this event. I'm sure that in the next 90 minutes, we'll have a very intense discussion, and we'll leave here much richer than we came. I think it's very topical. The area of men's health have been very neglected in most countries. We tend to focus broadly on health, but without disaggregating the data and looking at how we can strategize and have programs, especially targeting men. We have heard from the previous two speakers about the mortality among men, morbidity among men, the types of diseases that affect men. And when we look across the life cycle, the challenges that we have. Yet for many countries in the region, we do not have programs that would address these types of challenges that we have along the life course. I think we need to change that. And it is good if we can develop holistic policies at the regional level, and then help countries to develop particular national policies so that we can improve men's health. When we look at infectious diseases, as was mentioned, COVID has had a great impact on mortality, but also the more traditional infectious diseases, HIV, malaria, especially in some of the interior areas of our country, where malaria has been very prevalent and affects predominantly men who go out to do prospecting for gold. So this is an area that we have to look at. Compliance with taking treatment. A lot of men who have been infected, they don't want to take their meds, especially if it's for a prolonged period. And then when we look at the chronic non-communicable diseases, we have seen that amongst men, cardiovascular diseases, cancers, kidney diseases predominantly affect this age group. And of course, we also have mental health illnesses. We have seen all of this in Guyana, and we are working to see what we can do to address these issues. More recently, we have established a men's health unit in the Ministry of Health, and we have started to roll out programs that can address this. But we have very limited, or we are piloting some of these things. And if we're going to have an impact, we really need to do it at scale. And I'm sure that with the experiences and practices that will be shared here today, we will be able to learn more about what we can do to improve men's health in this region. So I look forward to the discussion, and thank you once again for inviting me. Thank you so much.
Thank you so much, Dr. Frank Anthony, for your open statement and for describing the situation in Guyana and the effort conducted in your country, and of course for supporting this important topic for countries in the region and the Caribbean. So I'm going to switch to Spanish right now. So ahora quisiera presentar a nuestros siguientes dos panelistas, el doctor Beno de Kaiser, investigador del Instituto de Salud Pública y docente de las Maestrías de Salud Pública de Género y de Salud, Arte y Comunidad de la Universidad Veracruzana, y a la doctora Sonia Café, asesora regional de salud adolescente de la OPS. Doctor de Kaiser, le paso a usted el micrófono, por favor.
Muchas gracias. Thank you very much. Good morning and good afternoon in Europe. Voy a presentar en español with the slides in English para mi mejor presentación y salud mental. Aquí vemos a tres hombres que están en la portada del documento que produjimos colectivamente, un gran grupo con OPS y sociedad civil en el 2019, que encabeza este reporte articulando las masculinidades con los resultados en salud, enfermedad y muerte. Y vemos aquí ya la interseccionalidad, la ruralidad, la clase social, el grupo etario al que pertenecen estos hombres. Es evidente en el pleno siglo XXI que el género no está en los genes, está en la cultura y está en los procesos de socialización donde vamos incorporando, incorporis, la palabra es muy interesante, vamos incorporando estos mandatos al grado de que parecen naturales y se pensaron como naturales durante mucho tiempo. Y esto se va incorporando a través de procesos educativos formales y informales, presiones y límites que también a las mujeres se le van colocando y que a los hombres en espejo se le van colocando de forma distinta. Los colegas del Instituto Promundo sistematizaron una metáfora que existe en el idioma inglés, que es la caja de la masculinidad, que en español sería como la caja del machismo, y que está compuesta de la incorporación de estos mandatos, la autosuficiencia. Yo no pido ayuda, ya sea que esté perdido en una ciudad o que necesite ayuda en salud o en salud mental. El ser competitivo, el ser agresivo, el pelear como una respuesta casi inmediata de muchos hombres. El atractivo físico, la fuerza física, pero no exagerada para no parecer metrosexual. Los roles rígidos heredados desde hace siglos en donde se privilegia el trabajo asalariado, pagado de los hombres, externo, y las mujeres, muchas mujeres todavía se ven recluidas o con una doble jornada en el trabajo doméstico y de cuidados. La heterosexualidad, que por sí sola ya sería parte, digamos, de una diversidad sexual, pero remarcada por la homofobia. Y esto en América Latina es tremendo en el habla y en el humor de los hombres. La hipersexualidad, un hombre de verdad jamás pierde una oportunidad de tener sexo y muchas veces sexo no protegido. Y la agresión y control, y aquí corrijo la palabra, es la violencia. El control, puesto que la agresión es esta capacidad animal de poder atacar o huir, pero la violencia es específicamente humana y tiene que ver con el poder. Tanto la violencia hacia las mujeres como la violencia entre hombres. Grande de las mujeres, pero los hombres seguimos gozando de privilegios a nivel económico, a nivel de las estructuras de poder, tanto nacionales como en el espacio doméstico, y esto tiene enormes consecuencias para las mujeres, pero interesantemente es una ventana también para observar las consecuencias en los hombres y en nosotros mismos, en otros hombres y en nosotros mismos. Aquí estoy inspirado por la triada de la violencia que generó Michael Kaufman hace ya un par de décadas. En el estudio fue notorio que hombres y mujeres, las estadísticas son muy binarias, ese es un gran problema que tuvimos, no se registra sistemáticamente otro tipo de identidades. Hombres y mujeres morimos más o menos en una forma semejante en las Américas después de los 50 años de problemas como la diabetes, problemas cardiovasculares o cerebrovasculares. Pero en este cuadro resaltamos las causas en donde hay un índice de masculinidad mayor, un contraste mayor con las mujeres. Y vemos causas violentas, son muy preocupantes y muy prevalentes en América Latina. Se decía al inicio que en el pico de la adolescencia es cuando hay mayor diferencia con las mujeres. ¿Por qué? Porque ya aparecen los homicidios, causas violentas, los accidentes de tránsito, los suicidios, hasta abajo los ahogamientos y la exposición a fuerzas mecánicas, que alude directamente a los trabajos más peligrosos que se hacen en nuestras sociedades, que los hacen los hombres. 3 causas de muerte ligadas al uso de sustancias, la mitad por lo menos de las cirrosis hepáticas, el consumo de drogas prohibidas y el consumo de la droga más permitida, que es el alcohol, con múltiples consecuencias. Y en medio aparece el VIH, que sigue teniendo una prevalencia mayor en hombres. Entonces esto va prácticamente del 67 al 88, casi el 90% de las mortalidades, de la mortalidad, y en el momento en que hicimos el estudio, había una esperanza de vida diferencial de 5.8 años entre hombres y mujeres. Pero si vemos la columna naranja, ahí está la presencia también de los hombres, en los homicidios, en los femicidios que se cometen en el continente. Es muy raro que una mujer mate a otra mujer. Incluso es muy raro que una mujer mate a un hombre. Y la mitad de esos más de 22,000 casos son cometidos por la pareja o la llamada pareja sentimental. Buscamos datos acerca de quién iba manejando cuando cerca de 38,000 mujeres en el continente mueren al año por accidentes. Y los pocos datos que encontramos es que hay una prevalencia de un chofer masculino, pero ese dato no se registra sistemáticamente. Si lo vemos a lo largo del curso de vida, ustedes en la parte de hasta abajo pueden ver los grupos de edad. Cerca de los 10 años ya empieza a haber una duplicación de causas que tienen que ver con accidentes, violencia interpersonal, nacimientos. Ahí aparecen más oscuros. Y esta tendencia de la presencia de muertes violentas se mantiene hasta los 50 años prácticamente, agregándose la cirrosis hepática y el VIH como causas de muerte. Ya después, decía yo, tiende a asemejarse al patrón de las mujeres. Y los años de vida perdidos, preciosos años de vida perdidos, son tremendos. Con una mirada interseccional, sabemos que esto no ocurre y estas vulnerabilidades no ocurren en una forma idéntica entre todos los hombres. Entonces, la clase social, ahí habla de pobreza, pero es la clase social, es un elemento. Ser migrante, ser joven es un riesgo en muchísimos países de América Latina, en México, en El Salvador, en Brasil, en Honduras. Ser indígena o afrodescendiente, las morbilidades ocultas y la falta de autocuidado, la no búsqueda de ayuda. No ser heterosexual o no parecerlo suficientemente puede ser un riesgo para la salud. Las prácticas de riesgo que llevan a muertes prematuras y el desempleo, que eso golpea fuertemente esta caja de la masculinidad. Aquí podemos ver la presencia de los determinantes sociales de la salud y hemos planteado que la masculinidad hegemónica es una determinante social de la salud, no solo de los hombres, sino también de las mujeres y niñas. La respuesta social. Es obvio que si yo mañana o el sábado en la noche me voy de fiesta y tengo un accidente o me intoxico, voy a encontrar atención. Entonces, sí, hay programas en todos nuestros países que atienden los accidentes, las violencias, el suicidio, el abuso de sustancias, el VIH. Pero todos estos temas están desconectados, no están articulados con una perspectiva de género. Y en la encuesta que hicimos con expertos de 12 países, vimos que sí hay programas, pero estos son marginales, muchos de ellos en la sociedad civil, son insuficientes y son tardías, M y T. Y la excepción, una honrosa excepción que ya tiene más de una década en las Américas, es el Programa Nacional o la Política Nacional de Atención Integral de Salud de los Hombres en Brasil. Este cartel dice, no importa qué tipo de hombre seas, fuerte, oriental, indio, sobrino, enojón, feliz, sé del tipo de hombre que cuida su salud. Incluso han avanzado a lo que llaman el prenatal masculino. Yo voy con mi pareja que está embarazada y me captan también para empezar a atender mi salud. Creo que es un buen ejemplo, junto con lo que han ido haciendo en Irlanda y Australia, que son los países que, en mi conocimiento, están en la delantera de estas iniciativas. Ya no pudimos incluir en nuestro informe este iceberg invertido. Habíamos pensado en un iceberg que se ve y que no se ve. Y como dice Peter Baker, está oculto a plena vista esta problemática, pero generalmente no articulamos todos estos problemas que aparecen ahí. Voy a mencionar algunos que no estaban: todos los daños materiales, los crímenes de odio, los cuidados no remunerados, la trata de personas, los altos presupuestos en seguridad pública, el tema de las consecuencias sociales, la cantidad de hombres que hay en situación de calle o en prisión y la paternidad ausente. Son toda una serie de problemáticas que aparecen dispersas, son claras en la sociedad, pero esta liga con la masculinidad está oculta a plena vista. Voy terminando. Las recomendaciones de nuestro informe plantean que hay que actuar en diferentes niveles. El sector salud generalmente recibe las consecuencias de esta educación de género hacia la desigualdad y la masculinidad hegemónica. Entonces tenemos que trabajar mucho más en una forma articulada con el sistema educativo, los medios de comunicación, instituciones que tienen que ver con el trabajo y con todo el bienestar social, las leyes, etcétera, para pasar de una interseccionalidad en el análisis de las vulnerabilidades a una acción intersectorial con perspectiva de género, tanto para mujeres como para hombres y población de la diversidad sexogenérica. La salud pública está muy ocupada en atender las causas de la enfermedad y detener, también tratar de prevenir. Ahorita estamos con la temática de COVID. Este planteamiento que hago no es vernos a los hombres como las víctimas del siglo XXI, sino qué vamos a hacer individual y colectivamente al respecto. Y también hay que ir aplicando la mirada salutogénica, ubicando los espacios donde los hombres sí están cuidándose, sí están cuidando su salud y la salud de otros y otras. En la medida que los hombres cuidamos nuestra salud, también vamos a ir parando otras inequidades de género y la violencia. Si estamos cuidando nuestra salud, también esto ayudará al cuidado de los otros y las otras. Muchas gracias.
Muchas gracias, Beno, por tu presentación. Ahora quisiera, now I would like to pass the floor to Dr. Sonia Café, who is going to present the report on men's health and masculinities in the Caribbean. Sonia, the floor is yours. We can't hear you, Sonia.
Can you hear me now?
Yes, now it's fine.
Excellent. Thank you very much. And I would like to thank and acknowledge the previous speakers who have already highlighted many of the items that I will be touching on in my presentation. It's an honor and a pleasure to share this platform with you. So what I will present is a summary of a report that we are finalizing on men's health and masculinities in the Caribbean. And the reason why PAHO chose, together with other partners, to embark on the development of a Caribbean-specific document are similar to reasons that were mentioned before by the PAHO Deputy Director, by Peter, by the Minister of Health, Guyana, that there is a growing interest in the health of men and boys and in the implications of masculinities. Beyond that, we felt it was important to do a more detailed analysis of the situation in the Caribbean, because that pattern of excess mortality and morbidity and risk factors, we also see that in the Caribbean. And so the Caribbean report that we are finalizing and that we will hopefully publish in the next few weeks, the purpose is to provide a more detailed analysis of men's health and masculinities in the Caribbean subregion, highlighting the Caribbean-specific issues and trends. And of course, our ultimate goal is to stimulate further discussion and to mobilize action, strategic action, to improve the health and well-being of men, women, and children, and to contribute to achievements of the Sustainable Development Goals for all men, women, and children across the life course in the Caribbean and in the region of the Americas. The methodology for development of the Caribbean report included a literature review. There is really a richness of literature available from Caribbean scholars on the topic of masculinities and men's health, analysis of health data, expert review interviews, and also data was collected from 8 Caribbean countries, including Guyana, to get a good sense of what is happening in terms of programs and policies. And so if we start with looking at the data, we see very similar patterns as what was mentioned by Benno. We see that there are excess deaths and also increased risk of death of men in the Caribbean related to preventable causes such as road injuries and interpersonal violence. This graph provides an overview of the status of the risk of dying, really, if we look at men of all ages. And men of all, if we look at this, all the ages, we see that men have almost 5 times greater risk to die from road injuries, and also the likelihood to die from interpersonal violence or homicides is also almost 5 times greater among men. If we narrow it down a little bit, looking at younger men in the age group 15 to 34, then the differences become even more marked. We see that when it comes to interpersonal violence or homicides, the young males, again, have a 4.5 greater risk of dying, road injuries, self-harm, almost twice, and what was also mentioned by Benno, the exposure to mechanical forces, almost 7 times greater risk, which is related to the types of employment, the types of work that males do. If we look at life expectancy, persistently, we also see this pattern that between 3 and 5 years differences between males and females when it comes to life expectancy at birth and life expectancy at age 60. And I don't have the images for healthy life expectancy, but we do see the same patterns when it comes to healthy life expectancy. Men have a lower and a shorter expected lifespan and a lower expected healthy lifespan. So what are some of the characteristics of Caribbean masculinities that we have identified in the literature review and the data collection, speaking with experts? Of course, there are similarities with other subregions, but there are nuances that are created by the Caribbean's history of slavery, indentureship, colonialism, and the racial ethnic composition of the region. And so it will always be important, and I'm advancing on the recommendations, it will always be important to study whatever evidence is generated globally and in the region, to study it and see how it, what the nuances for the Caribbean subregion. What are some of the key characteristics that I would like to highlight here? First of all, if you know the racial ethnic composition in the Caribbean, we know that we don't have a white majority, but we do have a racial ethnic hierarchy based on skin color and political power dynamics, because in the history of the Caribbean, politics have been strongly linked with race and ethnicity, and that continues to have an effect. Also, we see that males are dominant. They dominate public spaces, and here we speak about political leadership, judiciary, workplaces, and even though males underperform in education, the data indicates that in the Caribbean, men are more likely to be employed. And when they are employed, they do earn more. There are averages of between 20 to 30 cents more on the dollar compared with females in the same employment. Social status is very important, and that's something that we have perhaps in the Caribbean in common with what Benno was presenting. Power and control are characteristics of Caribbean masculinity, and those are gained through social class, education, and if it's not possible to gain that power and control through social class or education or social class, then aggression and risk-taking and violence take the place to gain that social status that is so important and such an important characteristic in Caribbean masculinities. Hypersexuality and heterosexism are also very evident in the Caribbean masculinity, and especially hegemonic, the dominant masculinities, a very strong rejection of homosexuality. And what was interesting is that this rejection of homosexuality is shared between men and women, as several studies have documented. And that hypersexuality and heterosexism drives the need to have multiple sexual partners to demonstrate that they're real men, sexual aggression, and concealing same-sex behaviors. In those working in the area of HIV in the Caribbean are very, very familiar with this phenomenon of men on the down low, of the men who are trying to conceal their sexual orientation and their sexual same-sex behaviors to not put in jeopardy their reputation and their status as a real man. The underperformance in education is a very important characteristic that is very long-standing. More than 20 years ago, there are articles, there are scholars who began to sound the alarm of underperformance in education on all levels of the Caribbean male. We know that it's a global phenomenon, and it was expressed in the UNESCO global report published this year, but it is a long-standing problem in the Caribbean community that affects health and well-being. Another characteristic is the absent father, which is more prevalent in the Afro-Caribbean communities. The Caribbean has one of the highest estimated rates of female-headed households. And on the other hand, the dominant father in the Indian Caribbean societies or groups with values that are inherited from the Indian ethnicity and cultural heritage, and limited ability to express bond, to express love, to express connection. And about these last three, if you read all the articles, there's a lot of debate because some scholars argue that this is very unfair because the Caribbean fathers do love their children and they do take care of their children. But here we are, and of course the values, dominant values that that are expressed in the Indian Caribbean culture are also changing. So there's also this recognition of evolving masculinities. And so when we try to address masculinities and men's health, we have to review the origins, and we have to review how they have evolved. What about men's health in services, men's health services and programs? It was already mentioned, limited engagement. Men are less socialized to promote and to maintain their own health. We also see that very much reflected in the Caribbean context. But we also see, on the other hand, some promising signs that there is a growing number of men's health programs and initiatives. Minister Anthony mentioned Guyana's efforts. We have documented efforts from the Bahamas, from other Caribbean countries that are beginning to develop men's health initiatives, programs, and services. But so far, according to the review, they are mostly ad hoc. There are some that are structural, but mostly ad hoc, ranging from dedicated services and programs to initiatives like the Men's Health Week, where there might be fairs and special events. But they're not structural and at scale. And there is no clarity on the incorporation of masculinities, the mainstreaming of gender in these efforts, these initiatives. And there's also no clarity on strategies to reach the marginalized males, as we mentioned, marginalized, sexually marginalized, socially marginalized males that really is a threat to their masculinities. In fact, some strategies actually play on the dominant masculinities to try and reach males, which further marginalizes males in situations of vulnerability. The areas that are addressed are often limited: sexual reproductive health, partner violence, responsible fatherhood, even though some countries did mention that they do address NCDs, NCD risk factors, prostate cancer, etc. Mostly in the countries, the literature and the countries that we engaged with, these efforts are led by ministries of health, but there are some partnerships with education and with civil society in the Caribbean. What we have also noticed that there is very limited monitoring and evaluation to really document what the results are of these efforts. We have also seen that the NGOs and development partners who are active, but it is important to harmonize and to collaborate the efforts between NGOs, development partners, and governments to maximize their outputs. So I will close with 4 key recommendations that came out of the analysis that was done in the Caribbean. First of all, we have to clear the path for the building of new masculinities theories and men's health programs. We have to make masculinities more visible, both the good and the bad, and masculinities as social constructs and not as inevitability, and also recognizing and inviting discussion to see how masculinities in the Caribbean can evolve to become more supportive of the health and well-being of both men and women. There is really a need to fill the gap in policies and programs. The minister mentioned that, and I think that has to be a strong push to review policies and programs and ensure that where they silence males and where they disenfranchise males, that they are corrected and that new policies and programs are developed that will really respond to foster healthier masculinities and address the needs of men. Health services need to be transformed. They need to take into account masculinities and use evidence-based or promising interventions to really transform services that respond to their needs. We have to do further research in the barriers that men face beyond commonalities and stereotypes to analyze the real barriers that men face to care so we can address them systematically. And of course, the need for further research in different areas, join forces to conduct further research that can inform strategic actions to improve the health and well-being of men in the Caribbean, addressing masculinities as social determinants of health that intersect with other determinants and that either echo these inequalities, or that can help improve the health and well-being of all men. I would like to acknowledge all the different stakeholders who contributed to the report, and we really look forward to sharing this report and using it as a tool to promote further discourse and further strategic actions. Thank you very much for your attention.
Thank you so much, Sonia. Excellent presentation, and looking forward to see the report published very soon. So I am sure you and Benno will have a lot of questions from the audience during the discussion, and especially about the concerning figures you presented and what else can be done and how to change that. So now I would like to leave the moderation to the next segment of the webinar to my colleagues, Jessie Should-Ain from PAHO and Professor Derek Griffith from Georgetown University. Jessie and Derek, the floor is yours.
Great. Thank you so much, Carolina. And thank you, Benno and Sonia, for two very interesting presentations, a lot of rich data, some recommendations. As we're now moving into the next session on lessons learned, and we will hear from two colleagues in presentations from the European region. It's always interesting and useful to hear what our colleagues in other regions are doing, and we'll have two presentations, one from the WHO European Regional Office and the other from an NGO. So I'm pleased to welcome our first speaker, Isabel Jorday, who is my counterpart in the WHO office in Euro, and she leads the Gender and Health Program in the WHO Regional Office for Europe, working with 53 member states in the European region. Over to you, Isabel. And thank you for being with us this morning.
Thank you, Jessie. Good morning, buenos días y buenas tardes a todas y a todos. I'm going to make my presentation in English, if that's okay with you. If you bear with me 1 second, I will share it. I would also like to say hello, not only to my colleagues, but to Noel and Peter, with whom I have been working in developing the European strategy. And first, can you see my, yes, I'm gonna put it on a slideshow. Can you see my presentation?
Yes, we can.
Yes, we're seeing it.
Thank you. So I wanted, my colleagues invited me to present the work that we did in the European region. And just to tell you that the European region sometimes is bigger of what we had in mind, and is not as diverse, but it's as the Americas region is, but I think it has a big spectrum of countries. So we go from the western part, from the country I come from, Spain, although we have Portugal more to the west, and to all the eastern part of the region on the border with China, everything that is the Central Asian Republic. So when we do a strategy for our region, it needs to accommodate this complexity and variety. Peter asked me to share our experience developing the strategy for the health and well-being of men that we took to our regional committee, our governing body of 53 member states, ministers of health, in 2018. So why did we have this strategy, how we developed it, what are the principles, the main issues, and what have we learned? First of all, to say that the men's health strategy came as part of a package of gender responsive health policy. We did take first the strategy on women's health to the regional committee in 2016. And already when we were finishing the strategy and the evidence report, during the consultation process, we also had many requests to have another one focusing on a gender approach to men's health. So we did. And I think that one of the parts that I like best of the work we did was the overall consultation process. I think we work quite close with civil society, and Noel was accompanying us and Peter all the way through on trying to identify also and get the rich experience and knowledge of what it is that we wanted to put into the strategy, because I mean, we had to prioritize and use the right approach. So we had a series of consultations, both in countries, from the eastern part of the region in Almaty to the regions for health in Switzerland, Sweden. So including as much diversity as we could do, and of course also in Ireland. And we presented the strategy in 2018 in the regional committee that took place in Rome. And it was endorsed with a resolution. And now next year in the regional committee on 73, we are going to do the evaluation or the lessons learned for both the women's and men's health strategy, because we do consider them complementary in terms of how to use a gender approach. Of course, I mean, as many of WHO strategies and using a public health approach, data was driving the agenda. And two of the key data that drove our agenda, it's something not very different of what was presented also for the cases in the Caribbean. But at that time, what was very striking, of course, you have the life expectancy comparison with women, but we saw, I mean, more than 10 years also of differences in life expectancy between men living in one part of the region and men living in another part of the region. And we knew also that the improvements that have happened in the last 16 years, and you have there in 2000 and 2016, were not great. So that was one of the issues we looked at. And we also knew that these are average comparisons, but if we were looking into in-country differences, we will find them as striking as when we look across countries. The other data that was also on the agenda, and it was also because at that time, non-communicable diseases was one of the main priorities of the European region, was also the difference that you see on the right figure, where we have the probability of dying for men before 69. So the probability, the so-called premature mortality. And if you look at the triangle that increases at the end, is that while if you look at respiratory diseases and cancers, there are no huge differences between East and West. When you look at the cardiovascular diseases, this was considerable. So in fact, in some countries of the region, we had 1 out of 3 men that will be dying for premature mortality because of cardiovascular diseases. So we did collect all the evidence on the report on men's health, and we were looking at different areas. We were looking at the governance. What do we do? We're looking at the responses of the health systems. We're looking also at the intersectionalities. I have to apologize because the website that you have there, the link, actually we are transitioning to a new website and most of the documents are not uploaded. So I did check before starting, and neither the women's or the men's health report are still uploaded, but they will be, and otherwise I can share them on a PDF file. So we have this report, and we were doing the report and the strategy at the same time in terms of the consultation. What were the key issues that we wanted to look at the evidence, and what were the key issues that we wanted to include in the recommendations? So the process of developing, compiling the evidence went in parallel to the process of consulting member states, academia, civil society on what would be the main priorities. So these are the principles that are actually gathering into the goal. And I think that for us was important to have that this should be evidence informed. the improvement of men's health and well-being, that it should be gender responsive and equity driven, and it should be transformative. So we wanted to have this also as everything, the exposure to risk and act as everything that acts as a barrier to gender equality and health equity. We were very much grounded on the Sustainable Development Goals. And I think that probably you are familiar with what we meant with gender responsive and gender transformative. And this is the scale that WHO uses for what we call the gender that it is in our gender mainstreaming for health managers tool, and it's called the GRASS, the Gender Responsive Assessment Scale. And so we wanted, our aim goal was going to gender specific and gender transformative. These are the three objectives that we had. So on the one hand, we were working using a gender approach as an accelerator to reduce the mortality of men from non-communicable diseases and unintentional injuries, as they reflected in SDG 3. We also have gender equality, SDG 5 as a goal, and it was very important throughout the discussion to have gender equality as a goal also, one by engaging men in self-care, in fatherhood, in unpaid care, and in preventing violence against women and improving sexual and reproductive health. And we saw that because, and we have evidence from some countries in the region where it says that gender equality is not only beneficial for women, but it's also beneficial for men's health. And then the third one is about reducing inequalities overall across the region. And so we wanted to ensure that we could reduce inequalities between men of all ages across the region and within countries. Some of the issues that we highlighted it was the policy coherence. We wanted to emphasize that gender is also a determinant of men's health, and that men needed to pay attention within gender policies. So there is part of gender policies looking at discrimination and gender equality issues having an impact on women, but gender as a determinant of health was largely invisible. We were very keen on having the life course approach and how to make emphasis on early child development and how positive and healthy gender norms need to start there. Leave no one behind, and using an intersectionalities approach, including men experiencing multiple vulnerabilities from gender identity, migrant status, disability, etc. I think that the European region does not have an emphasis, a strong emphasis as the Caribbean may have on race, but it is also reflected on ethnic minorities. We focus on adolescents, starting to promote inequitable patterns of health, sharing parental responsibility on care and violence against women. This is all the part related to gender equality. But we also have the big responsibility of the health services and the health system responding to men's health needs, and especially strengthening primary health care and mental health. And there was a last part on health promotion, which was emphasizing the main risks that men are facing, and they have been very well described by the two previous speakers. And using life transitions, and we did identify 3 life transitions that could be used as opportunities: adolescence, fatherhood, a very important one, and retirement, because we did see the decline on health that retirement may imply when you have the breadwinner model. And we saw that as an opportunity for reaching men. And then meet men where they are. And I think that Noel will probably speak more about all the work that is being done in the European region and beyond, with the barber shop, with the men's sheds, and men talking to men and engaging men. So some of the follow-up actions were actually driven already when we started working. We have a report on mental health and masculinities. It was included the cardiovascular cardiovascular diseases in the big health system conference that was held in Sitges. We did it on the analysis of 3 countries for health systems barriers to NCDs. But also there are a lot of programs that are dealing with men's health where we are trying to make a dent because it's not being used as a gender approach yet. This is one of the main pieces of work we did, which was looking at the existing vast amount of information that the STEP surveys, which are the surveys that look at the risk factors for NCDs, had disaggregated by sex, but a thorough gender analysis had not been done. So we did make this analysis in 8 countries, and we are currently doing it in Tajikistan with the purpose of including the findings into the NCD's national policies. So finishing with the lessons learned, we found that the evidence was a big entry point and tool in countries where there may be a resistance to either masculinities or a gender approach. Using the evidence and putting it forward was one of the main tools we had, and we are investing on strengthening that evidence. We also wanted to avoid competing agendas, and we have put the men's and the women's health under an overall and complementary strategy. And also member states asked us in 2018 to do the reporting and the evaluation together. Important highlighting difference among men between and within countries and using an intersectionalities approach. And even countries that have very high life expectancy and overall indicators which are positive for men and women's health, highlighting difference within countries was very powerful. We try to build into current priorities, and these are the current priorities now. So we don't create a parallel masculinities, men's health or women's health agenda, but we strengthen that whatever are the priorities in the European region, the gender approach, men's health, masculinities, and women's health and femininities are well grounded. So we are focusing now on mental health, digital health, primary health care, and I didn't put there also long-term care. We also continue to work on the gender equality agenda, and that we do very much through the care part, the gender transformative care patterns, and we want to highlight the violence prevention. I already mentioned the transitions, but I also find that there is a need to strengthen programmatic areas that do focus somehow on men, but they don't use a gender or masculinities approach, such as HIV, TB, prisoners, violence and injuries prevention. So I think that we have an untapped source there, and this is another area we need to work further. And thank you very much. I think that Noel will continue. And hi, Noel, good to see you.
Isabel.
Wonderful, thank you, Ms. Jorday Aguirre. Really appreciate your presentation. Next up, we have Dr. Noel Richardson, certainly an expert in the area of men's health research, policy, and advocacy. He's the principal author of the first ever national men's health policy, which was published in Ireland in 2009, and then the follow-up men's action plan, national men's action plan, published in 2016. As Isabel said, he's been a policy advisor for WHO and various other initiatives, both across the globe and certainly in the European region. And he's a board member of the Men's Health Forum in Ireland and a member of Global Action on Men's Health. So I could go on about his various accolades, but we should just go ahead and hear from Dr. Richardson. So thank you so much.
Thank you, Derek, for those kind words, and lovely to see some familiar faces here today and to see such a high number of participants on the webinar. I'm really pleased to share with you today Ireland's experience of developing a national men's health policy and give a kind of a context and a background to that policy. But in particular, I'd like to share with you as well the key lessons learned in transitioning from policy development to implementation. So I'm not going to speak about the kind of rationale for developing a policy. I think Isabel has covered that in really good detail in relation to the EU strategy. And essentially the same momentum factors were evident in Ireland. So I'm going to focus more on the nuts and bolts of developing the policy and what kind of lessons other jurisdictions might take from Ireland's experience. So this gives you a sense of the kind of the key timelines and in chronological order and the key milestones in terms of developing the policy. I'm not going to dwell on all of these, but I think a couple are worth mentioning in particular. The first is really important, the fact that men's health was identified as a priority goal in our national health strategy in 2001. And this reflects a lot of work that went on in the preceding 10 years, both from top-down ministry and statutory service personnel, but also from bottom-up civil society members who kept canvassing and advocating and lobbying for an increased focus on men's health. So this pressure, this advocacy eventually led to the naming of men's health on a national health strategy. I'd also point to the consultation process. And Isabel has already talked about the importance of consultation in the EU strategy, but this was hugely important in the Irish context. Not alone in terms of canvassing people's opinions and priorities in relation to what a men's health policy should look like, but more importantly in terms of building relationships, building collaborations and partnerships, which were the cornerstone on which policy implementation was based afterwards. So that consultation process, which included a very lengthy and drawn-out process, phase 4, of consulting with the lead agencies who were being tasked with implementing goals in the action plan that accompanied the policy. That included 6 government departments, many of whom didn't see men's health as a priority at all at the start. So it meant quite a lengthy process in terms of making the case, building a rationale, and also building relationships, as I said. And this was hugely important afterwards. So this gives an idea of the timelines. So Getting Inside Men's Health was the research, a special commission research project that informed the initial policy. The initial policy was accompanied by a 5-year action plan that went for external review in 2014. And the recommendation was that a more streamlined action plan would be developed as the second action plan. So that was Healthy Ireland Men. And that has just expired recently, and we're currently reviewing the second action plan with a view to having a third action plan by the end of this year. So the detail of the development of the policy is laid out quite coherently in these 2 papers, which I can share with anybody afterwards, if you would like to get more detail about the mechanics of how we went about the consultation process in particular. So what was our overall approach to policy development? Well, firstly, it was firmly integrated within existing government policy. So we weren't trying to start with a greenfield site. We were trying to link national men's health policy to other aspects of policy, both within and beyond the health sector. It identified clear accountability and leadership tasks. So we had a very detailed action plan that accompanied the first policy, over 100 actions, and each action was accompanied by a lead agency who was responsible for implementing that action. Placed a firm focus on the gender nature of key men's health issues, such as alcohol, obesity, and mental health. And over time, I think we've moved from a gender-sensitive approach to a more gender-responsive and gender-transformative approach. Sorry about that. It also adopted the social determinants perspective with a focus on health inequities. So we're in particular focused on more marginalized groups of men and disadvantaged groups of men. Targeted interventions both an individual and a population level, incorporated a community development approach, particularly in terms of building relationships with NGOs and leaders that would provide access to more marginalized groups. It adopted a strengths perspective. So it wasn't about naming and shaming men. It was about working from a strengths-based, salutogenic approach to masculinities. And it focused on prevention and supporting men to become more active agents and advocates for their own health. In terms of governance, because I think this is really important when it comes to policy implementation, the policy was overseen by a national implementation group that was co-chaired by the Department of Health and a Health Service Executive member. There was an annual plan and a progress report at the end of each year. There was an attempt to align the policy with other policy priority areas. As I mentioned earlier, it went for external review at the end of 5 years, and the second action plan is currently being reviewed externally. There was an annual communication strategy, which was about profiling and highlighting key men's health issues for that year, and in particular around Men's Health Week, to create awareness around men's health issues. There were explicit links to a gender mainstreaming framework and working with women's health. Evaluation, research, and knowledge translation was a key pillar of the policy, and 2 research centres in particular became very proactive in terms of aligning with NGOs and statutory organisations and bringing an applied or action research approach to a broad range of men's health initiatives. And there was some cross-departmental work, but overall that was challenging, but some inroads being made. If we just highlight one example here, the Department of Agriculture was one department we consulted with originally, and we made very little progress in the first iteration of the action plan. But more recently, we've got 2 national programs that are working with the Department of Agriculture. One is a cardiovascular disease prevention program, working with farmers in workplace settings, and the other is a training program, training agricultural advisors to act as health connectors with farmers. So there were programs that didn't get off the ground immediately, but it's an example of where patience and building relationships and, over time, that can lead to positive outcomes in the longer run. So the review of the original policy that Peter actually did recommended a dedicated national focus on men's health in Ireland, but it also recommended the development of a revised, more focused action plan for men's health that would support the effective implementation of Healthy Ireland. So the original action plan was very ambitious, over 100 actions, most of which weren't achieved at the end of the 5 years, I should acknowledge. So the recommendation was clearly to have a more kind of honed action plan that would align with the key priorities of our national health strategy, Healthy Ireland. So this is the second action plan that's just finished and is currently under review. So given the time, I'm just going to run through a couple of examples of some of the key successes of the policy. The first is the links, as I mentioned earlier, between research and knowledge translation and the development of toolkits, training programs, and resources, many of which were linked to national men's health programs, like Sheds for Life, a health promotion program for men in sheds, Men on the Move, a physical activity program targeting inactive men, and Farmers Have Hearts, a cardiovascular disease prevention program targeted men in Marts, and more recently, Cordia, which is a program targeting suicide prevention in the construction sector. So these are all examples of programs that are either in the process or have been scaled up to national programs. And the key point I'm trying to make here is that they wouldn't have been possible without close collaboration between academia, NGO, civil society organizations, and statutory health services. And that's led to a really productive and varied program of research activity. Training has been a critical element of in terms of developing capacity among service providers, and engaged our national men's health training program that has been on the go now for over 10 years. Initially, it started out as a generic training program to equip service providers with the skills and competencies to more effectively engage men. But over time, new modules have been added, such as focus on young men, middle-aged men, and more recently with a focus on training agricultural advisors to engage more effectively with farmers around health. Men's Health Week has been a huge factor in our national men's health policy. This is coordinated by the Men's Health Forum in Ireland with over 100 partners, and it's had a key role in raising awareness and raising the profile of men's health in Ireland. Okay, so in terms of key lessons learned, So I've kind of synopsized these into 2 slides. Identifying men as a target population group at a national health policy level, copper-fastening the political will to prioritise men's health. So having men named in a national health strategy originally provided an important kind of rationale and momentum to go ahead and develop the policy. Because just before the policy was launched, it coincided with a really big recession in Ireland. And I think there is a real danger that the policy might never have got published if it wasn't for the fact that there was a commitment in our health strategy to develop and launch a national policy. The consultation process, as I mentioned, not just informed policy development, but underpinned the partnership model that was the cornerstone of policy implementation. So I can't emphasize this point enough. The relationship building, the partnership and collaboration that was the cornerstone of the consultation process really stood us in good stead in the longer run. The need for transparency in managing expectation and signposting policy decision making, that's really important because policy can only reach so far. And as we discovered, the first 5-year action plan was far too ambitious given the resources we had to implement it. So you can't be all things to all people. So there is a need to prioritize and to agree timelines for actions. And there needs to be transparency in that process so that everyone is aware of the decision-making underpinning the prioritizing of some areas over others. The importance of having strong governance and accountability measures in place to maintain a focus on men's health. Policy is only as effective as the governance and implementation structures that are there to oversee its implementation. Without those, policy can't be effective. The importance of leadership and advocacy in getting and sustaining men's health in a policy agenda. Again, I would stress the importance of top-down leadership as well as bottom-up leadership. So we had some key allies in the Department of Health and in the statutory health services who maintained the momentum on men's health, as well as the advocacy groups I mentioned earlier, like the Men's Health Forum in Ireland and the Men's Development Network. So that top-down, bottom-up approach is really important. Partnership has been a key element, as I mentioned. The highly significant role that Engage played in building capacity to support policy implementation. So that didn't just equip participants with the skills to engage men. It was also designed to change culture within organizations and to get more focus on men's health. The importance of balancing ideological versus pragmatic approaches to men's health. So the first action plan was broad and aspirational, but it did set out our stall in terms of what was important. The second was more pragmatic. Growing the evidence base through research is really important. Approaching other sectors on a win-win basis. Patience is really important. Having communication strategy and profiling success is really important. Using the policies as an implementation tool for a national health strategy is important. And excellent relations with women's health with gender mainstreaming has a limited impact. Conscious of time, so last slide, key take-home message. I would advocate that there is a really value in having a men's health policy. It identifies men's health as a priority area. It creates a vision, identity, and branding for men's health. It provides a framework for action and a roadmap for practitioners. It gives leverage to expanding men's health work because it's underpinned by a policy. It supports intersectional and gender transformative approaches to service and program delivery. And it offers an opportunity to apply a gender lens to other policy agendas. So sorry for rushing there, but that's it. Thank you very much.
Great, thank you so much, Dr. Richardson, for that very practical and useful presentation. We are now moving into a discussion session. And so I know we have some questions on the chat. We have about 10 minutes and many of you online. So what we encourage, and I think this has come up from some of the participants too, if you could please share your comments on the chat and any questions as well. We'll do our best to try to read out as much as possible and see and field some of the questions. We've had a lot of rich discussions and learning today from learning more about the context around masculinities, the determinants, policy, the data and information that is just coming out now from the Caribbean. And we've got examples from different parts of the world. So there is one question that came up early on that was about disabilities. And I'd like to direct that to Dr. Sonia Cafe about the research that was done and if it included men with disabilities.
Yes, thank you. This is a very important question. We tried in our review of review of evidence and of articles to look at different vulnerabilities and marginalizations in different sectors. And so, yes, we did identify issues related to men with disabilities as, again, an added layer of marginalization and vulnerability that has to be taken into account.
Great, thank you. We had another question here, and you know, unfortunately, we don't have a whole lot of time. But there's a question, teniendo en cuenta que el propio sistema de salud reproduce las normas rígidas de género, quería saber si había experiencias de trabajo con universidades para incorporar la temática en las currículas de medicina y ciencias de la salud. This is coming from Juan Carlos Escobar. I was thinking that we could direct that question to Benno.
Mm-hmm. Yes, gracias Juan Carlos. Tú y yo sabemos los problemas que hay que tienen que ver con el género en el propio sector salud, que creo que no se ha hablado mucho. Médicos, médicas, enfermeras, las relaciones de poder que se establecen en el propio sector salud y la poca visión de género que se tiene, no solo en las políticas, sino en el trato cotidiano con hombres y mujeres, niños y niñas, adolescentes que llegan a los servicios de salud. Ese es un gran reto que tenemos en el sector salud, que todavía está muy biologizado y todavía muchas veces con el enfoque materno-infantil. Ese es un gran reto. Y de ahí nos vamos a la formación en las universidades y en la formación del personal de salud, en internados y residencias, hay muchísimos problemas también de maltrato, de acoso, que se mantienen silenciados en nuestro continente. Entonces creo que tú estás apuntando a esta necesidad. Yo actualmente estoy colaborando en un segundo año con la Universidad Nacional Autónoma de México y ahí estamos tratando de volcar toda la experiencia que hay en género, pero también en masculinidades, hacia la comunidad universitaria, hacia profesores, hacia autoridades, hacia estudiantes, construyendo estrategias múltiples que apunten a la no violencia y la igualdad de género. Entonces creo que es una experiencia bastante novedosa, sobre todo porque incluye un programa integral de trabajo con hombres que estamos implementando con una perspectiva comunitaria y preventiva de desigualdades y violencia.
Thank you. So we're going to take one last quick question and then close. This question I'll pose to Sonia, Dr. Cafe, if you don't mind. There's a question about, besides Brazil, what countries in the Americas are working on adopting national level men's health policies, and which countries are closest to implementation, and what we can do to help these efforts get to the line. I think Benno, actually, both between the two of you, may be able to speak to that question quickly, and then we'll close as well.
Thank you, and Sonia is fine. So we have seen this clear commitment in the PAHO member states have insisted on an indicator on men's health in the PAHO strategic plan. And when we say PAHO strategic plan, it's not a plan from PAHO as an institute, but PAHO, the American community. And so they have insisted on an indicator on men's health, and they have given us as Secretariat the task to develop policy guidance on men's health. So there is a clearly defined commitment in our region that is growing. When we look at which countries have developed policies and plans in the Caribbean, specifically, as the minister mentioned, Guyana has developed a men's health plan or strategy. The Bahamas have developed. I know that in some of the Latin American countries, there are some countries that have developed plans of action or specific actions articulated in policies or programs for men's health. And some have indicated that they are currently developing. We are actually planning to update our inventory of where countries are at this time. I cannot mention the numbers, but I know that there is a growing number of countries that are developing or that have recently developed men's health strategies or policies or plans.
Thank you. Noel, did you have anything to add before we close? You're muted.
Sorry. Creo que bajo estas tremendas estadísticas que presentamos para América Latina y también se presentan para Europa, Isabel mencionó la importancia de esta dimensión de la salud mental, ¿sí? Cuando vemos las estadísticas que tienen que ver con adicciones, con suicidio, con homicidio, están gritando la temática de salud mental. Y poco a poco, así como hay que desmedicalizar la mirada, hay que ir psiquiatrizando también la mirada para poder acercarnos a una salud mental muchísimo más amplia, muchísimo más incluso positiva en términos del manejo de las emociones. Y también leyendo las preguntas, esta visión todavía no se logra totalmente pasar de la planificación familiar a una visión mucho más integral de salud sexual y reproductiva y de derechos sexuales y reproductivos que están bajo amenaza, no solo en Estados Unidos, sino en muchos países de Latinoamérica. Esto mencionar, por ejemplo, que Costa Rica ya tiene acuñada una política nacional de salud para los hombres. Hay un Centro Nacional de Equidad de Género y Salud Reproductiva que ha hecho un trabajo muy importante en México. El trabajo que hace Juan Carlos con adolescentes en Argentina. Los padres que ya tienen derecho a estar presentes en el nacimiento de sus hijos e hijas como un elemento de salud reproductiva importantísimo. Gracias.
Gracias. So to close, I want to give the last bit of the floor to Dr. Vega. Thank you for being patient and apologize. We're running a bit behind. Dr. Vega is the Regional Advisor on Aging and Health and the current Unit Chief for the Healthy Life Course Unit, PAHO. He's also a Professor of Gerontology and Geriatrics at Medical University of Savannah, where he's been for about 30 years now. So thank you. The floor is yours.
Muchas gracias por la presentación, muchas gracias a los panelistas por su participación, muchas gracias por haber tenido la participación que hemos tenido. Yo creo que a pesar de que todavía tenemos importantes sombras en el conocimiento sobre el tema de salud de los hombres y masculinidades, yo creo que fue claro en el panel que tenemos la evidencia necesaria de la necesidad de trabajar sobre este tema. También tenemos la suficiente experiencia acumulada para empezar a trabajar y a intervenir con acciones positivas en estos aspectos. O sea, a pesar de lo que tenemos que aprender, yo creo que los panelistas nos dejaron claro la necesidad de los enfoques integrados. Yo creo que aquí ha sido muy claro que la necesidad de un enfoque de género, la necesidad de un enfoque de equidad, la necesidad de un enfoque a través de los determinantes sociales de la salud, la necesidad de un enfoque de curso de vida, necesitan de su integración a la hora de enfocar especialmente la salud de los hombres y traducirlo de una manera efectiva en la política pública. Ahora, claro que tan solo trabajar a nivel de la política pública no es suficiente, tenemos que lograr estrategias e intervenciones que logren intervenir de manera clara en lograr una cobertura y un acceso efectivo a lograr trayectorias de salud y desarrollo mucho mejores en los hombres de nuestra región. Así que les agradezco a todos por la participación. La OPS-OMS se siente honrada con las colaboraciones que hemos estado teniendo en estos temas y estamos dispuestos a ampliar y extender esa cooperación de la manera más efectiva posible para que toda esta experiencia trascienda a nuestros países. Muchas gracias y espero que reciban pronto la grabación de este seminario para que pueda ser distribuido y difundido la mayor posible. Gracias a todos. Muy buenas tardes.
Thank you, everybody. Bye. Have a good day.
Thank you.
Thank you. Gracias.
Gracias a todos.
Yes.